At the end of this episode, you should be able to understand the origins of the Melrem's refusal of transport policy, name the elements which are required to evaluate a patient refusing transport or treatment, name conditions that, if present, necessitate transport under implied consent, name the criteria which may prompt a discussion with medical control prior to refusal, name the elements of the patient interview that must be completed prior to allowing a patient to refuse transport, and become familiar with the documentation of refusal of transport.
Refusal of transport is a significant risk to EMS agencies, EMS personnel, and EMS systems. When you look nationally, one of the biggest medical legal expenses is around patients who refuse transport and then have significant medical illnesses. Because of that, we have to have a strong, secure refusal of transport policy. The policy that has existed for the last couple of years was developed specifically to address the issues around how does an EMS provider evaluate and determine which patients can refuse transport and which patients have to be transported to a hospital under implied consent. We've had a lot of experience over the last couple of years, and now this new revision of the policy has come together as a result of a couple of things. First, we've actually worked together with police, mental health, EMS to determine the legal aspects behind, the state legal aspects behind the ability to refuse care and the idea behind mental hygiene arrest. The other piece of this is that after EMS had used the previous policy for a couple of years, we found the bugs, if you want to call it, in the policy, or the challenges that people would run into in the policy. And this revision, along with the educational component that's going with it, is meant to address those challenges and those bugs so that we can make life easier for the EMS provider who's trying to decide, can this patient refuse my care? Can this patient refuse transport to a hospital?
Refusal of transport creates high medical legal risk for EMS agencies. The Monroe-Livingston refusal of transport policy helps standardize our protocols and protect EMS providers, their agencies, and the Monroe-Livingston EMS system.
Sure. Well, as we approach any patient, right, the first thing that we want to do is just a visual assessment, and you determine that when you walk up to the scene and identify that they are unconscious and unresponsive, and therefore you provide care according to implied consent. In other cases, you are determining whether or not there is a mechanism that would be concerning for this. Again, if there are two cars that have hit each other in a parking lot and there's no significant vehicle damage, then already you're not terribly concerned regarding the mechanism. Whereas someone hitting a tree at a high rate of speed with significant vehicle damage, that would make us concerned for there being a significant mechanism, and therefore if they are refusing, I want to get a little bit more information. How they're walking, how they're talking, all of that stuff we can do in a visual assessment. Ideally, we are also obtaining an initial physical assessment. What are their vital signs? What is their gross physical exam? Is there obvious bleeding? Is their airway patent? Is it going to stay patent? Are there vital signs within accepted parameters? Sometimes it's just anxiety, which means, okay, that's okay. Take another set of vital signs, make sure that if the patient is refusing, vital signs are coming back to normal and there are no other significant concerns, that maybe it's appropriate for that patient to refuse care. A focused exam should certainly take place if an individual states that their wrist hurt because they fell down. A focused exam just to that wrist to identify if there's any obvious deformity, decreases in pulses, motor, and sensation, and so forth should occur at that point in time. And then lastly, and probably most importantly, is whether or not they have decisional capacity or the ability to make medical care decisions. And that really falls into a number of additional questions in terms of, one, are they altered? And do they demonstrate an altered mental status? If they have an altered mental status, then they probably cannot make those decisions. That mental status may be because of organic causes, a head injury. It might be because they are significantly intoxicated at the time. So that comes into play. Does the individual have the ability to verbalize what's going on? Why was EMS called? Yeah, they called the ambulance because I was involved in the car crash. I don't feel like I have any injuries. That's important for the individual to understand and articulate their understanding as to why was EMS there to begin with. The second component is making sure that the individual can articulate in their own words what they are refusing. And that they are refusing additional treatment, additional transport, that we have recommended that they are transported. For example, in the case of a motor vehicle accident with loss of consciousness, that we are concerned for a head injury that we cannot diagnose in the field, and therefore you could have injury to your head, brain, bleeding, coma, seizures, death, etc. If the individual can relate that back to you, then that demonstrates that they have comprehension of those risks and therefore is comfortable in accepting those risks. Obviously, they need to either be an adult or an emancipated minor, because they, again, at least in New York State, if you are under 18, you cannot make those decisions without discussing it at least with their legal guardian. And even if that's by phone, that's certainly acceptable in certain circumstances.
So there's really a lot of different aspects to the question of what does the EMS provider need to know and need to do in order to determine if a person can refuse care. Ultimately, for me, it comes down to whether or not they have decisional capacity if they want to refuse care. So, can they understand what you're explaining to them? Can they reflect back what you've explained to them, thereby showing not only have they heard you, but they've processed it, synthesized it, and said it right back to you? Can they, in addition to that, or do they, in addition to that, not have something that would possibly confound their presentation? So it could be alcohol on board, such that it impairs their capacity, drugs on board, such that it impairs their capacity, or they're actively suicidal, and therefore you can't necessarily take what they're saying completely at face value. For children, there also becomes the issue of legal guardians. Obviously, a 4-year-old really is not allowed to refuse care if EMS was called for that individual. So there's the issue of legal guardianship that also plays into it. Now, when you're trying to determine decisional capacity, you have to assess the patient, and there's multiple steps to the assessment. When I'm teaching EMS providers and even medical students and residents, you can actually tell them you can do a lot of assessment without touching the patient. What do they look like? If they're tripoding and working really hard to breathe, or if they're lying on the ground not appearing to be responsive, that's going to take you in one direction than the person who's sitting up chatting with you like you're at the mall. The other thing is an actual assessment of their vital signs. Are they hypoxic? Are they tachycardic? Are they tachypnic? An assessment of their being, of true physical assessment. Those are all really key factors that you need to be able to do when you are evaluating the patient. And then on top of that is the determination of decisional capacity. So a patient that wants to refuse transport has certain conditions or certain presentations that would disqualify them from being able to refuse transport. One is that they have altered mental status. Someone who you come across who's obviously confused cannot, because they're not going to be able to exhibit decisional capacity. Another one is someone who exhibits or indicates the threat to harm themselves or harm others. Now this becomes a little bit tough because it could be a passive or active threat. They could say, I'm going to go run out in front of a bus, or they can make a lot of comments that lead you to think they care so little about their life, they're going to hurt themselves. Those both need to truly be considered. Another condition that needs to be considered is if they can't verbalize an understanding of their illness or their situation, especially the risks associated with refusing transport. If the person doesn't get it, that the fact they have a significant laceration on their leg that's bleeding significantly, that shows that they don't understand the situation, therefore they cannot refuse transport. And finally, it comes down to the pediatric issue of there's no legal guardian present to help. If a 4-year-old's there, an 8-year-old's there, you need a legal guardian to be able to actually not transport that patient.
Conditions which may make a patient ineligible to refuse transport include altered mental status, threats to harm self or others, lack of understanding of their condition and the risks that it poses, and pediatric patients.
So there's only one circumstance in which providers are expected to contact medical control prior to obtaining a refusal, and that would be in cases of an apparent life-threatening event. So that's an event in someone less than 2 years of age that was clearly threatening or concerning to the provider at the time. Baby turned blue, baby was choking, etc. Those are circumstances, given the importance of having them transported to the hospital, that we request that providers contact pediatric medical control and make sure that the physician is involved in relating those risks to the parent or the caregiver. And again, that's not to undermine the paramedic or the EMT's ability to convince family. It's really to help support them and reinforce the importance that our system places on individuals that have experienced an ALTI to actually be evaluated in a hospital setting. There are a number of what we define as at-risk criteria, meaning these are criteria that the provider should think about. Obviously, if there are significant derangements in vital signs or extremes of age, that the provider should just take a few more minutes to make sure that it's reasonable that this patient refuses, that there are no other conditions that may be masking, for example, a heart attack or child abuse or mistreatment in both extremes of age. That the provider should take that couple extra minutes of time when an individual exhibits those at-risk criteria to ensure that the patient or the caregiver truly understands the risks of refusal. In some cases, and in certainly not all cases, it may be helpful to contact medical control. And generally that's a provider judgment. By no means is medical control required for at-risk people. We simply use that criteria to help raise a red flag, if you will, to the provider when they're making an assessment that if someone has those at-risk criteria, that they are just that, they're at-risk criteria. So just double check those specific variables to make sure that the patient's making an informed and appropriate decision.
What's primary in this is the ALTIs, the apparent life-threatening event among essentially very young children. This condition has been associated with significant illness, and therefore, whenever there's a case like this, where a child that's an ALTI, their parent wants to refuse transport, doesn't want to go to the hospital, medical control must be called because the physician needs to talk to the parent to really do a second opinion, essentially, and say what the paramedic or the EMT said is truly true, and I'm going to say it again. There's another set of criteria that we've clarified that put patients at least higher risk, and these are criteria that should be considered by the EMS provider who is deciding whether or not a patient can refuse. Patients with these criteria, you should consider calling medical control in order to get the second opinion, if you want to call it that, on whether or not the patient should be allowed to refuse. And also, quite honestly, when there's a physician on the other end of the phone, patients may be more likely to accept transfer. I've frequently been on the other end of the phone and saying, "Sir, you really should come. I'm waiting here for you." And the patient says, "Oh, okay. We didn't add anything significant," but sometimes it just takes that added second opinion. So what are those criteria? Criteria is very old or very young, age greater than 65, age less than 2 months. Another criteria is pulse greater than 120 or pulse less than 50, systolic blood pressure over 200 or less than 90, respiration greater than 29 or less than 10, a serious chief complaint. We talk about that as being syncope, shortness of breath, chest pain. The two other criteria on that's fever in a newborn less than 8 weeks of age, and also an injury with a significant mechanism that could be of concern. So those are the criteria, and it's right on the refusal form, because I certainly can't remember it, and everyone's not going to be able to remember this. So you can think about it and say, do I need to call med control? Is it a good idea to call med control? Or I'm comfortable here, they meet the criteria, we don't need to call med control.
Apparent life-threatening events require consultation with pediatric medical control prior to refusal of transport. Other conditions which may prompt an EMS provider to call medical control include significantly altered vital signs, extremes of age, a potentially serious chief complaint, fever in a newborn less than 8 weeks old, and a significant injury mechanism.
So best practice for going through a refusal, if you will. Once you've identified that the patient certainly has the ability to refuse, and in your opinion, it's reasonable and appropriate, there's a number of things that we should do really for the patient's benefit. The first is obviously making sure that the patient understands the nature and the consequences of their decision. That we have offered transport to a hospital, that we have explained the risks of refusing that treatment, and that by refusing care or transport, there's the possibility of serious injury or death. We should always advise them to seek medical attention or follow-up care. And then most importantly, we need to confirm with the patient that they understand these. The best way to do that is to ask them to repeat back to you, what did I just say? Do you understand? And have them relate back to you. What are you going to do if your symptoms get worse? Oh, I'm going to call 911 again, or I'm going to follow up with my regular doctor, or what have you. It is important that the individual signs an appropriate refusal of treatment or transport form, although just a signature is not enough to identify that the individual made an appropriate decision. It's really going through that informed refusal process. Whenever possible, we should leave the patient with a responsible adult. So in the instance of someone that may have been drinking but demonstrates decisional capacity, obviously we would want to leave them with someone that is sober and appropriate. Similarly, if it's a minor, we would want to leave them with a responsible adult. Even if it's an elderly individual that we've assisted from a standing position after what appeared to be a mechanical fall, we would want to leave them with a responsible adult. We should obviously always remind them that should they want the ambulance back, should they change their mind, they can always call 911. That we're more than happy to come back. We'd certainly encourage you to do that. We take no offense to you refusing care. We want to help you. We understand that this is the decision that you've made, but we want you to also know that we're always there for you, and we're certainly going to respond should you request us again.
Key questions in completing a refusal of transport interview include: does the patient understand their condition? Do they know transportation to a hospital has been offered? Do they know the risks of refusal? Have they been advised to seek follow-up care? And do they know that they can call 911 if needed again?
One of the most frustrating encounters that I know as a provider is when you are on scene with a patient who does not meet law enforcement's criteria for mental hygiene arrest. They're not a threat to others or themselves. They're not complaining of suicide or suicidal ideations or what have you. But I am clearly concerned for their health and well-being. They have a significant cellulitis or stroke symptoms or something along those lines. And a lot of times I feel, quite frankly, helpless. Some of the things that we can do is a lot of what we've already talked about. It's making sure that the individual understands these risks, engaging law enforcement as is appropriate. Sometimes just their presence helps. Engaging family members, physicians, their primary care physician perhaps engaging medical control to have another physician do that. Sometimes gender is important, so maybe my interaction with a female patient might not allow that female patient to be as comfortable, similarly to a male patient for a female provider. All of those things we should try to do. If we reach that impasse, if we reach the point where it is my opinion as a pre-hospital provider that this person really needs to go to the hospital, however, law enforcement does not feel that they can mental hygiene arrest, I ultimately cannot force them to go to the hospital. And with great reluctance, I have to allow them to refuse care. With that, obviously, I want to document as much as I can. If I can speak to their primary care physician and let them know what circumstances that we're under right now and that I would like them to try to get followed up upon in a short period of time. If I have another caregiver, ideally a parent, friend, neighbor, etc., that's something that I want to try to empower them to be connected with. In some cases, perhaps a social services referral may be appropriate as well, given the home environment and so forth. That might be another thing that I can do. But ultimately, unfortunately, I cannot force them into the back of my ambulance, even if I have questions regarding their decisional capacity. And in some cases, this may take 45 minutes, an hour and a half of convincing and time and so forth. And those efforts are valid, they're appropriate. But ultimately, if law enforcement does not feel that it is an appropriate mental hygiene arrest, and they are not unconscious, I cannot force them to the hospital. So using all these different techniques may be helpful in getting a good outcome, but ultimately there are circumstances where, to all of your best efforts, you're not going to be successful. The refusal of care form helps the field provider, whether it's the paper form or if it's embedded into an electronic PCR. The goal of that form is to help remind them of the criteria. What are the high-risk criteria? What are the things that I need to use to help determine whether or not they have decisional capacity, intoxication, age, and so forth. It also reminds me of all the things that I should remind the patient of, that we want you to call 911 again if you want to be reevaluated, that we want you to articulate back to me the reasons for refusal. And obviously it includes the refusal of care attestation that ideally should be signed preferably by a non-crew member. Family member is best, law enforcement second best, another crew member kind of third, but certainly someone else. So that's simply used as a tool to execute a relatively lengthy policy.
Your documentation itself facilitates the refusal of transport process. Be sure to use the correct paper or electronic PCR form.